Hey everyone, and welcome back to the show. I'm your host, Taylor Chapman, and this week I'm sharing an exciting conversation with Dr. Eric Abbott, an Air Force veteran and Doctor of Osteopathic Medicine. He's currently working as a family medicine practitioner for Optum Medical. Now, mental health is a common subject these days, but a less common topic of discussion are the detrimental effects that can take place when we don't keep our mental health in check. You see, we're all busy, we're all stressed out, and things don't seem to be getting any easier. So let's dive deep into how we can better manage our stress while maintaining our busy schedules and understand the risks if we don't. This is the Veterans Voice podcast, and this is a reminder that you're not alone.
I'm dating myself now, probably. It's a rap group back in the day. They had this song called Microphone Checker. It's like going by microphone check, microphone checker. So, sorry.
I'll make that the opener.
Did you record that?
Yeah, I've been recording for a little bit. But, all right, Dr. Abbott, welcome back to the show, brother. How's it going?
Good. Good to see you, sir.
Yeah, for sure. How's your holiday weekend?
Not bad. Not bad. Little drizzly, rainy, gray. But I can kind of dig that too. But kind of pulled the mood down a little bit a couple times. I was like, wow, this is not Seattle. Come on.
Yeah, the weather hasn't been good, but so much deserved time off, I'm sure.
Yes, absolutely. Much needed.
For sure. Well, I've had you on a couple times. It's always a pleasure having you on the show. I really enjoy our conversations. So
always.
Today, we're going to talk about stroke and mental health, specifically men's mental health, because it's been a hot topic recently. So I just kind of want to get into it with the increased suicide rate in men, over women, almost 2 times more likely to commit suicide over women.
Right.
And then, tapping into the veteran community, we have a lot of male veterans, unfortunately, going that route. And I just want to do our part here at Mount Carmel and the Veterans Voice podcast to kind of counter that. So we're going to get into it.
Sounds good.
Well, let's start with stroke. I don't have much experience with stroke. I know there's a couple different types: ischemic stroke, hemorrhagic stroke. I know a couple of the risk factors, but how about just from a doctor's point of view, what is a stroke?
Right. Well, basically, a stroke is when you have a blockage of circulation to a segment of the brain, and the brain needs a lot of oxygen and a lot of glucose. And when you're having a stroke, it's deprived of both. And typically it's a specific region of the brain. So sometimes you can see deficits, neurological deficits that reflect the region of the brain that's damaged. And basically, if it runs out of oxygen, then it'll just kind of start to die, kind of like heart tissue does. So if you have lack of oxygen, blood flow to a piece of the heart, that's a myocardial infarction or heart attack. Same thing happens to the brain, and they call it either a transient ischemic attack or a stroke. And you've got a couple different types of strokes: hemorrhagic stroke and an ischemic stroke. So the most common type is the ischemic stroke. That's basically you've got a little fleck of plaque that breaks off one of your arteries, and you can have, as a consequence of that, platelets that will flood in and try to cover that piece that's broken off, and it'll generate a clot, which can then propagate down the blood vessel and end up, the blood vessels are branching smaller and smaller and smaller into capillaries. So once they get to where the capillaries have branched small enough, then it'll occlude something. And then that's when there's not enough blood flow, and you'll see some really clear signs of a stroke. Hemorrhagic is more just that literally the blood vessel has ruptured open. Some people have little aneurysms, which are like bulges in the blood vessels in the brain. Tends to be hereditary. So there's like a family history of that. If your old man has had one of those, you have a higher incidence of that yourself, and so forth. So sometimes people get screened for them, actually. And under the circumstances of really high blood pressure, or there could be head trauma. So we see that a lot in the military. Veterans can have TBI and things like that. And that can cause different types of hemorrhagic stroke, where you've got a brain bleed And that brain bleed, because of the skull, is obviously not that flexible. It's actually a little flexible, but not that flexible, right? The brain tissue will start getting compressed as the blood is filling up inside of the inside of the cranium. It'll press on the brain and can cause some deficits as well. It starts to kill the neurons.
Okay, I see. Is there a more common type, hemorrhagic versus ischemic, or?
Ischemic is more common.
Right.
And that's typically just coming from high cholesterol. Is so really oversimplified. It's high cholesterol and high blood pressure are the two reasons for that.
And it's I'm just kind of, to dumb it down a little bit, it sounds like it's a blockage of one of the tiny vessels in your brain.
Correct.
I'd imagine there's a lot of very minuscule vessels up there.
Right.
But when your body identifies that, it sends what did you call it? White blood cells, or what attacks it?
So you'll have white blood cells that'll rush in. You'll have platelets that'll rush in and try to sort of heal over that area of plaque that ruptures off. Sometimes you'll have, so a typical picture is, let's say someone's got diabetes.
Right.
And they're, as a consequence of having diabetes, their blood vessels are always inflamed. And so when you consume cholesterol, especially too much cholesterol, sometimes you can have a combination of platelets, which are designed to create clots, cholesterol, fibrin deposits, and things that will go in and try to correct or heal where that inflammation has occurred inside the blood vessel. And the best way to reverse that is to reverse the inflammation, right? So you control your blood sugars, you control your blood pressure, things like that. But high blood pressure, high blood sugar cause that inflammation.
Right.
And then eating, certainly smoking, can also, the toxins inside of cigarette smoke, the tar and nicotine and so forth, and many other toxins besides, right, cause even more inflammation in the blood vessels, which can predispose to that plaque formation.
I see.
And just stress hormones.
Yeah.
So catecholamines like norepinephrine and epinephrine and high cortisol levels, being constantly in a state of hypervigilance or stress, can also put you at a higher risk for literal inflammation of your blood vessels. And so over time, you can have a plaque that will just start to lay down these concentric layers of plaque, and it'll get bigger and bigger. And then you can have an episode of really high blood pressure where it just shoots up and it can knock off a piece of that plaque. And then your body goes through the same mechanism of trying to cover it and fix it and repair it. And that response can actually end up creating a clot that can propagate downstream and block off pretty important portions of the brain. Yeah. And it's all important, right? Your whole brain is important. So
that's what I was imagining. It sounds like it's not just the plaque, it's your body's response to the plaque. And now you have this buildup of platelets over the plaque, and it's the buildup of platelets that might do that final closure to cause the blockage that causes the stroke.
That's correct.
So your body's trying to help you, but at the same time, it hurts you.
Correct.
That's kind of scary.
Yeah, absolutely.
Well, you kind of touched on it a little bit, but let's dive deep into risk factors. Is this a hereditary thing? Is this a preventable thing? What are some of the leading risk factors in stroke?
Right. Well, the literature says that 80% of strokes are preventable, which is reassuring.
Yeah.
Right? The highest risk factors for stroke, number one, is just family history. So if your mom and dad, heaven forbid, if they had strokes, you're definitely at a higher risk for having a stroke. Or another first degree relative like a brother or sister. So mom, dad, brother, sister, if any one of those have had a stroke, you're definitely at a higher risk, and you have to really keep an eye on your labs and blood pressure and things. Number one risk factor is hypertension after the family history. Family history you can't do anything about. Hypertension you can. And that's something that's really missed in American culture, probably all over the world, but definitely in American culture, it's missed all the time. Yeah. People will not go to the doc for 5-10 years, and then they'll come in and realize their blood pressure is, 200 over 110 or something like that. And we're trying to rush them off to the emergency room for further evaluation. They wonder why we're so excited. And I always tell them, well, it's because you're going to blow a gasket,
right?
Which is
literally
blow a gasket, right? So a translation is that they could have a hemorrhagic stroke from that, actually. So that's like an immediate short-term effect of blood pressure that high, is having a hemorrhagic stroke where technically one of your blood vessels just pops. That's the short-term effect. Long-term effect is that, like I was saying, it just damages your blood vessels, and you don't want anything damaging your blood vessels because they feed everything, right? And then the next, of course, the smoking we talked about with the toxins, high blood sugars is damaging, drinking in excess, really drinking at all, to be honest. There's really nothing healthy about consuming alcohol, as it turns out. It's just kind of bad for everybody. Can you do it and in moderation and probably be fine? Absolutely. I'm not saying like no one should ever drink, but you'll hear things like, well, it can raise your HDL cholesterol. Well, yeah, that's true.
Yeah, a glass of wine a night or something like that.
Correct. But I think the overall effect of alcohol consumption is more harm than good. Let's put it that way.
So is it the alcohol that's raising your blood pressure that's increasing the risk, or what's like the physiology behind that?
Absolutely. So alcohol raising your blood pressure is part of it, but then also just literally the alcohol itself is a toxin. And so that gets into your bloodstream and your body has to work extra hard to process that. Your liver has to work extra hard to process it. And the presence of it being in your bloodstream, it just causes some damage to your blood vessels. It actually damages the liver as well. And it'll start to enlarge, and you'll start to develop fatty liver. And your hepatocytes, the cells that make up your liver, will actually start to break open, and they'll release proteins into your bloodstream, and we can monitor that on lab. So I can tell just by looking. I see this all day long. I'll look at somebody's complete blood count, and I'll look, or actually their metabolic panel, comprehensive metabolic panel, and I'll look at their liver enzymes, and I can tell. I'm like, do you drink at all? And they're like, yeah, and I'm like, yeah, I can. They're like, how can you tell? I'm like, well, it's right here, So
you're seeing an elevated liver enzyme, and what that is the liver literally breaking down?
Correct.
Wow.
So it has a similar effect, one could say, or an analogous effect on your blood vessels.
Okay.
Yeah.
So high blood pressure, alcohol, what are some other risk factors?
And then I would just say definitely blood sugar is too high. So your average blood sugar, like first thing in the morning, should be less than 100.
Right. And
I don't expect everyone to go out and check their blood sugars, but that's a normal blood sugar. People with diabetes, they're usually clocking in at like 126 or above first thing in the morning, like a fasting blood sugar.
Wow.
And that's if they're relatively mild diabetic. But I've seen diabetics in my clinic that will have fasting blood sugars 200, 300, 400. And that is super, super dangerous.
Right.
And sometimes they're doing that in clinic, let's say, plus their blood pressure is like 200 over 110 or whatever. So those are kind of the biggest ones: blood pressure, blood sugar, the high cholesterol, particularly LDL cholesterol. So low density lipoprotein is the quote unquote bad cholesterol. The good cholesterol is HDL. So you want that as high as possible. High density lipoprotein. LDL, low density lipoprotein, you want that as low as possible, ideally below 100. Triglycerides are another one that can kind of raise your risk of stroke as well. So you want those below 150. And beyond that, I mean, those are the ones that we're most focused on. A lot of people get pulled into focusing on total cholesterol,
right,
and they say, oh, my cholesterol is 150 or it's 200 or whatever. But that's what we're really looking at, are the components more than the additive number. We're looking at the additive number 2, but the LDL is the one that we're really focused on.
Okay. How about gender? Does this affect males versus females differently?
Yes, men are at a higher risk for stroke. 100%. In fact, they have something like nearly a 2% higher risk of developing stroke than women. It's number one killer for men, especially women. Stroke is. Women deal with strokes as well, but just the prevalence is not as high. So it's more so for men. a lot higher for men. And why that is, it's just like a testosterone thing, right. I think.
Yeah, testosterone
primarily
increases your red blood cell count, increases your hematocrit, and I would imagine that increased density of the blood,
right.
thickening of the blood would cause some kind of buildup at some point.
Correct.
And we were going to kind of touch on that too. You know, having increased levels of testosterone in men could be a risk factor as well.
Correct. Yeah.
If you want to go into that a little bit.
Absolutely. I mean, some people have high hematocrit, which is the thickness of your blood or number of red blood cells per unit volume, and hemoglobin, but it's more so the hematocrit that we're looking at, where they need therapeutic phlebotomy, or they'll go in and literally it's like leeches kind of thing. They don't use leeches anymore, right? Sometimes they do, actually, but for the most part, leeches are not used anymore. It's just they draw it off. They call it therapeutic phlebotomy, and that can help to get the crit down, hematocrit. That's more with conditions like, we're kind of veering off a little bit, but more like something called polycythemia vera, which is a condition where you just generate too many red blood cells. And that typically is not associated with your testosterone levels.
Right.
However, if you happen to have that underlying condition, you would not be a good candidate for taking testosterone, because that would just worsen your condition. A lot of people these days are looking to supplement with testosterone because they've heard, it gives me more energy and it'll increase my libido. It'll increase my muscle mass. In many cases, this is true. It will do all those things, but it'll also raise your hematocrit, your hemoglobin. Definitely put you at a higher risk for just developing clots anywhere in your body, particularly heart attack, stroke, pulmonary emboli, blood clots in your legs and that kind of thing. And I have been telling my patients that for probably consistently for probably the last 6 months to a year or so. And then I'm like, it's interesting. I haven't seen this yet. And one of my colleagues actually says that his one of his patients developed a blood clot because he had an elevated hematocrit. Would not, I don't know what the story was. I don't know if he just wouldn't come off the testosterone or if it wasn't caught early enough or whatever, but he ended up having a clot as a consequence of that. So now he's going to have to come off completely.
Yeah.
It wouldn't even be ethical to keep him on it,
Yeah. So is that a sustainable thing if you're maybe a male, late 30s, 40s on testosterone, nothing, abusive level, but you continuously every 6 months have increased red blood cells, increased hematocrit, and you're doing a therapeutic phlebotomy. Is that what it's called?
Right. Yep.
You're donating blood to kind of keep that down. Is that a healthy cycle to constantly be in?
Not really the healthiest, probably.
Right.
Could that happen? It could, but if you're constantly counteracting it with therapeutic phlebotomy, just like any other process, like eventually it's gonna break down somewhere.
Right.
Maybe he's out of the country or out of town, or there's a bump that we're not looking for. How often do you do this? We don't really know, right? There's no exact science behind it, and there's no way that we can know from month to month necessarily what someone's hematocrit is unless we're just testing it all the time. And it's just my personal feeling is that if you've gotten to that point, you probably need to back off. And we'll usually suggest a lower dose. We try to talk them out of it, but no one wants to hear that,
Once you feel it, you don't want to come off it.
Exactly. Yeah.
Any other risk factors you can think of?
Those are the primary ones. Believe it or not, like I said, stress is a big one. In fact, stress is a very non-specific word, right? It's like, well, what does that mean exactly? But we've all experienced it. We all know what it feels like. That can actually do a lot of things to your cardiovascular system. One is just raising catecholamines or stress hormones. And when that happens, that's in some ways as bad as smoking and drinking and all this other kind of stuff.
Wow.
One could almost argue that it's worse because it's very endogenous. It's always there. You know what I'm saying? It's something that's a little bit harder to dial down than just how many drinks you're consuming or whatever.
Yeah.
And so that does the stress hormones do also have an inflammatory effect on just your body in general. including your blood vessels. And then stress can actually do a lot to the body. It's actually been demonstrated by cardiologists in Japan that if you have someone that's in acute bereavement, that can actually change the structure of the heart. It's called Takotsubo syndrome. So if someone has lost their spouse and they're bereaving, they're in bereavement, the heart, instead of having like sort of an upside down pyramid tapering kind of shape to it, it'll actually end up looking like a flask where it's like bigger on the bottom and it kind of tapers upward. And the cardiac output goes down, and it actually affects like how well the heart is operating, can actually put them into potential heart failure. It's called Takotsubo syndrome. So it's called broken heart syndrome.
Yeah, I'm trying to think why that's actually happening.
I don't think anybody knows.
Yeah.
But it's a response to that. My personal opinion or feeling is that it's just like stress hormones are having an effect on the myocytes, the cardiac myocytes. So stress is huge. Like it's not benign, Yeah. And ironically, people smoke and drink and eat bad food to counteract their stress.
Yeah. So what's worse at that point? I'm not stressed, but I smoke a pack of cigarettes and I drink every night.
Exactly.
Interesting.
Yeah.
Well, let's counter some of these risk factors. So going back to high blood pressure, how might someone decrease their risk of increasing their blood pressure?
Right. So best thing you can do, like we were just talking about, stress management's helpful, right? So mindfulness is really popular these days, and it's also another word that's kind of vague. Well, what does that mean, right? It's just kind of being present, being in your body, and kind of focusing on your breathing and sensations. What do you see in front of you? What do you feel? What do you smell? What do you taste? That kind of thing. Because we tend to get really caught in our heads all the time, and we stop breathing. People are actually shallow breathers a lot of the time, where they'll literally just stop breathing, and they're breathing up here versus like down here.
Right.
Cardiovascular exercise with diabetics in particular is probably good for everybody. The guidance is 150 minutes a week of cardiovascular exercise, like moderate. I don't approach 150 at all, but my philosophy is like, if you do 5-10 minutes a day, that's sufficient. 10 minutes a day is far better than an hour a week kind of thing.
Okay.
An hour once a week,
And you're saying like a 10-minute walk where your heart rate simply gets elevated from your baseline?
Yeah. Brisk walk, light jog, exercise bike, swimming. If you incorporate some weights in, so much the better.
Right.
But that can really help to blow off a lot of steam in terms of like your stress levels as well. But then also just raising your heart rate. And I don't have the specifics on the off the top of my head about like what's your target heart rate. I mean, people can Google that and determine what's their target heart rate per age and weight and that kind of thing.
Right.
That does lower the basal. It increases your basal metabolic rate. It lowers your heart rate. And this has a tendency to kind of, through a mechanism I don't know, but it will decrease your stress hormones.
Right.
So that's definitely helpful. There is debate about salt and like a so-called low salt diet, right? That's a little bit harder to track because it depends on your activity level. If you're out running and doing CrossFit and all this stuff, and you're losing a lot of sodium, a low salt diet's not going to be the best thing for you. But you're also probably not dealing with a lot of hypertension because you're so active. You know what I'm saying? But there's something called a DASH diet that basically is just like a cardiac or a low salt diet. So that's something that people can look into, discuss it with their doc. So that can definitely help. Things that reverse the inflammation I'm talking about. Fruits, vegetables, green leafy vegetables, whole grains, unsaturated fats, like canola and olive oil, things like this are really going to help. Fish and fowl and things with like vitamin E, omega-3 fatty acids, and those things will lower your cholesterol, lower your overall inflammation. And abstaining, which is like, it's like a terrible word, the A word, but abstaining from drinking and smoking, or at least minimizing it. If you have to do it, or if you're really attached to it, then just try to dial it down.
Yeah. I'm thinking back to the exercise. Like, it can be intimidating to start an exercise regimen if you're at high risk of high blood pressure, but just doing something as simple. We all work at desks, I think the majority of our day, but every hour doing 20 air squats or so, that takes you like a minute or two.
Absolutely.
Just get the blood flowing again. Your heart rate increases a little bit. That has to be helpful over time.
Oh, 100%. Yeah. Like those little so-called baby steps or whatever, it's like none of that is lost on your body. Your body remembers everything you do and everything you say, everything you think. Like nothing gets past your brain and your body. It all registers either positively or negatively. Yeah. So getting adequate water intake throughout the day, and those little exercise breaks or stretching break. I worked in a clinic when I was in active duty that was just downstairs from like physical therapy, was upstairs. So in between patients, I'd run upstairs and do like a set of pull-ups and come back down. And people are like, where were you? And I was just like, they're like, oh, you're having a rough day, aren't you? I'm like, yeah.
Man, that's funny.
Doing some pull-ups.
That just reminded me of a story. My old first sergeant, when I was stationed at Fort Benning, he always thought that it wasn't fair that smokers could take a break every hour. Yeah. And so all of us non-smokers would go out and there'd be a pull-up bar right next to the smoke pit. So we'd be doing pull-ups while they were smoking. And then we all got 10 minutes off every hour.
Perfect.
And then he banned smoking after that because he just thought it was ridiculous. But yeah, that was just a funny story.
Yeah. No, stuff like that is perfect. Doing pull-ups, or if you can bring some free weights into the office, do some curls, like while you're on a meeting, like on speakerphone or something like that. They have those under the desk elliptical
I saw that,
things. I don't know how effective they are. I've never used one, but
better
it's
than
like,
nothing, I'm sure.
But you're moving, There was a nurse that I saw at one of our clinics that had a treadmill actually like at her desk. So she would be on the treadmill, not like running, but she was like, just kind of doing a lope or a moderate walk, and she was on the phone with patients. And it's there like you can always do something. You can take a stroll around the office, while you're taking a call or something like that. So it's like if you want to incorporate it, you can find small ways to do that.
Yeah, absolutely.
The Veterans Voice podcast is sponsored in part by Optum and is produced in the Optum Podcast Studio. Optum and Mountain View Medical Group offer 20 clinics throughout the Pikes Peak region. Their primary and specialty care doctors provide quality, patient-centered care backed by Optum's leading health services and technology. They are dedicated to helping our community live healthier while keeping care affordable. Visit optum.com/Colorado today for more information.
Just going back into stroke, what are some of the signs and symptoms of stroke? I would like to do, preliminary signs and symptoms like labs, blood pressure increasing month over month, but then, in the moment someone's having a stroke. Let's touch on both.
Right. Absolutely. So indicators of I guess, looming stroke, which I see all the time, normal blood pressure, average adult, we'll say less than 140 over 90. That's kind of what we're shooting for.
140 over 90.
Less than 140 over 90. Yeah. So if someone is clocking in at 140 over 90, we're kind of keeping a beady eye on that. We're like, okay, we should probably recheck that. Maybe have you check your blood pressure at home. See if it's elevated at home. Is it just white coat syndrome? Meaning like they're just nervous because they're at the dock kind of thing. I don't wear a white coat, but also for that reason I don't, because it's like, I think it's kind of intimidating.
Yeah,
so
totally
it's like,
get it.
I don't want their blood pressure to, and then let's say it's like, 150s over 90s, 160s over 100s and things like this, which I do see. Unfortunately, I see that. I'll typically ask them right there in clinic, hey, you feeling okay? Are you having any chest pain, chest pressure, chest tightness, shortness of breath, dizziness, headache, blurry vision, slurred speech, weakness, numbness, tingling, confusion. And they're like, usually, no, doc, I'm fine. Sometimes they'll say they have a headache.
Yeah.
And I'm like, really? You've got a headache right now? They're like, yeah, my head is pounding right here. And their blood pressure is 190 over 110, or sometimes 200 over 110, something like that.
Right.
Those are the patients that I will say, what I would recommend is that you go to the emergency room for further evaluation, have them get some labs on you, determine, get some urine and some labs, make sure everything looks okay, because you can definitely develop a hemorrhagic stroke out of a blood pressure that elevated.
Right.
Or they could throw a thromboembolic stroke or have an ischemic stroke as a consequence of that. And some people take my word and they go. Others say, no, I'm fine. And I'm like, all right, well, here are your ER precautions. So if you do develop these symptoms, then you want to go to the emergency room. And so that's kind of what we're seeing as things lead up to it. And then acutely, if it's happening, similar to that list that I was giving the patient, where classic symptoms are weakness. So they'll have weakness in an arm or a leg. They can't lift their arm, or they go to walk and they can't ambulate. They can't walk straight. They're kind of listing to one side.
Right.
They have double vision or blurry vision. They have facial droop, or they can't feel. They have a facial droop and they can't feel half their face. They can't feel their hand. They have tingling and numbness and things like this. And sometimes they can have a headache. That's less common. They could have definitely a headache, particularly if it's a subarachnoid hemorrhage.
Mm-hmm.
That's kind of like the classic worst headache of your life sort of thing. So if you have a headache that comes out of nowhere and it's the worst headache you've ever had, and you're having weakness and numbness and things, definitely call 911.
Right.
Trying to think what else. So those are the big ones. And confusion, just difficulty understanding someone speaking to you, or difficulty speaking. We'll typically tell people, repeat a phrase, like no ifs, ands, or buts. And then if they have a hard time saying that, it comes out garbled and slurred and things, we know there's probably something going on. We'll have them kind of put their arms straight out in front of them like this and close their eyes and see if they can hold it. And if one arm is constantly dropping, then you know that they've got a deficit they've got a right-sided deficit, let's say, if it's happening over here. So likely the left motor cortex is being damaged by whatever's going on right then. Those are the typical things that we're looking for. But you'll see all kinds of stuff. You'll see people just getting very tearful or confusion. They're just definitely off, and they know something's off.
Right.
So there's an acronym for it where essentially you look at their face for the drooping of the face, numbness and things like that. And then arms, we talked about, just making sure that they can kind of hold their arms up, or it's like that sobriety test. We have them close their eyes, their arms are out to the sides, and they can, touch the nose kind of thing. Mm-hmm. And if they're going up here and down here and all over, that there's definitely a problem.
Right. Speech and then time.
Yes.
Yeah.
The slurred speech, which we talked about. Yeah. I was coming up with a different acronym in my head for something else. So slurred speech, definitely just difficulty speaking. And then finally, if you've got a combination of those things going on, then you've got anywhere from, let's say that the stroke onset was just then, like right then, and you were there. Then ideally you get them their thromboembolic, their clot busting therapy, their meds, IV clot buster, within 4.5 hours. So you want to get them to the emergency room as quickly as possible so that they can be evaluated, get a CAT scan of their head, see is it a hemorrhagic stroke? Are they seeing a bunch of blood collecting around, or is it potentially a thromboembolic stroke? And then they get their labs and things done, and they can get into the lab and get that infusion done. Alteplase is actually what they use, which dissolves clots.
Right.
And it works really well. The issue is that you'll have someone develop these symptoms 3:00 in the morning, whatever, they blow it off, they go back to sleep, and then they'll tell a family member the next day, hey, this is what happened. It's too late.
Yeah. What do you mean by too late? Like kind of irreversible or death, or how does this play out?
Too late meaning that it's too late to treat it with an IV thrombus dissolving medicine like alteplase.
Right.
That it's in many cases, let's not say all, but in many cases, it's not really going to be helpful at that point. Now, it could be that someone has just had what's called a TIA, or they have these symptoms that pop up, transient ischemic attack. Symptoms pop up and then they resolve within 24 hours and they're back to normal. That's best case scenario. It's also best and worst case scenario. Right. It's a best case scenario because the symptoms are not staying. It's not an ongoing neural deficit, but the likelihood of them having another stroke or another transient ischemic attack within the next 90 days is pretty high. So that lets us know that they're on the wrong track,
right.
And something needs to be done. There needs to be some sort of intervention. And they may end up getting put on Plavix, which is like a medication for sort of an antiplatelet med or dual antiplatelet medication regimen like Plavix and aspirin or something like that. That's
blood
kind
thinners,
of blood thinners, and that's more of like what type of stroke it is and the weigh-in from neurologist and things like that.
Right. Okay.
So those are best case scenario. I have a family member who had a TIA a while back, and he actually responded or came out of that pretty easily. Sometimes they will actually lose a little bit of brain tissue, so that's not a TIA. That's like a full-on like actual stroke where you actually have brain damage that stays. And they can have a deficit, but it's minor. You don't even necessarily notice it. Like they just have some weakness in their hand, whereas before they didn't have that, and things like that.
Right. I'm going to go into kind of recovery from a stroke. It would obviously depend how long the obstruction was present, how fast they got treatment, but what does recovery look like on average for someone who's had an ischemic stroke?
Well, typically recovery starts more or less immediately, certainly within like 48 hours of the stroke. And the first thing you do with those patients is you'll do something called like a swallow eval. So just making sure that it's it's a speech eval / swallow. They kind of go together. Speech eval and swallow eval kind of go together. Seeing, can someone speak clearly? Can they still articulate? Can they still drink liquids, eat solids, so-called manage their secretions, because you don't want someone going home and they're like literally choking on their food or on their own, on their own saliva kind of thing. So that's kind of one of the first things you look at. And then you get a full neurological exam. You're sort of cross-referencing that with the imaging and determining, okay, this person's got a deficit in their right hand and left upper leg, let's say. So we translate that to this area of the brain. It does indeed show that on CAT scan and MRI. So we'll do an MRI as well with and without contrast to see, was there an aneurysm? Was there, where exactly in the brain was it? And then neurological exam, that kind of thing. And then they start focusing on rehab, physical therapy, occupational therapy to essentially monopolize on neuroplasticity and get those nerves to start growing back. Because to some degree, you can get nerves to grow back and people can regain their function. Not always, though, right? There are some cases where, unfortunately, they're going to have paralysis of the right side of their body, like indefinitely, that sort of thing. But in a lot of cases, people can really regain a lot of function that they may have lost during that. So they get set up with that, any sort of home health kind of stuff they need, and just to get on a rehab schedule and make sure they're on the correct medications in terms of antiplatelets and cholesterol meds and things like this. Oddly, the blood pressure that was once a risk factor that actually ended up causing the stroke in some cases, when someone has just had a hemorrhagic stroke, a lot of times you employ something, if they're inpatient, they're in hospital, you employ something called permissive hypertension, where you actually let the blood pressure ride a little bit higher so that there is enough blood flow to the cerebrum, to the brain.
Right.
Because you don't want to turn that down to less than 120/80 now, or down in the 116/70 and things like that. You don't want to overtreat the blood pressure, because then they won't get enough blood flow to that portion of the brain that was already damaged and it's trying to heal. So
Right.
you let it ride a little bit higher, and that's as precarious as it sounds. And you definitely need to be I need to be consulting with people who know exactly what they're doing and that kind of thing. So that's when I'll be on the phone with neurology and asking questions and kind of giving them the proper treatment moving forward. So,
Okay. How about just some, just your perspective, general lifestyle choices or changes someone can make to avoid stroke in general?
right. Yeah. I would just say primarily make sure that your blood pressure is within normal range. It's not a bad idea to get a blood pressure cuff for home.
Mm-hmm.
The wrist ones are not great in terms of accuracy. It's better to have the upper arm cuffs.
Mm-hmm.
You can get one of those online pretty easily or at your pharmacy. And it's good to look online and see what the proper technique is. You have to have like both feet flat on the floor and your arm resting on something, and your upper arm about heart level and resting for a few minutes. Legs aren't crossed. You're not talking to someone at the same time, and really get a good measurement. You just kind of typically have a box with some batteries in. You hit a button, it just self-inflates, and it'll spit out a number. And you really want to try to stay within normal blood pressure range, stay on top of your blood pressures in that way. So check it like once a week. And then if you're a diabetic, you obviously just want to stay on top of your blood sugars. If you're relatively neurotic like myself, and you're a little bit pre diabetic, then is it wrong to check your blood sugar once a week, like to see if it's where you're clocking in? It's not. Do we recommend it? No, but I do it.
Right.
I'll be honest.
Yeah.
So
might as well.
I just try to keep an eye on it.
Yeah. I get my labs done every 3 months. My doctor thinks I'm a little bit excessive.
Well, and I are the same that way. I mean,
Yeah. I do have a blood pressure cuff at home. I check it every morning, and I usually ride around between 110 and 115 over 75 to
Perfect.
80.
Yeah.
So is there any like low end that you don't want to hit? Because sometimes I will be at like 108 over 70 just on any given morning.
Yeah, no, those are fine because you're fit, you're in shape and things like that. Now, if someone is taking blood pressure meds and they're that low, then we have to be careful. But if that's just your normal blood pressure, in most cases, like it's fine,
Okay.
Unless you're like really having lightheadedness and dizziness and you're like keeling over and stuff like that.
Right.
And then we need to investigate that and figure out, okay, why your blood pressure is so low. Is there something else going on, like hormonally or whatever? But typically, I tend to run around the same as you, like 116 over 75.
Yeah.
At baseline, that's about where I'm at too. So it's like just relatively, we're both relatively fit. I'm not as fit as you are, but
Yeah, I don't know about that. What could be going on hormonally though for someone with low blood pressure like that?
Sometimes they can be dealing with, I want to say it can be related to something called multiple endocrine neoplasia or an MEN tumor. And definitely don't quote me because I don't remember the exact details right now, but you can have people with like way too low blood pressure. It's like a cortisol. Sometimes it's a cortisol issue, and we have to check their cortisol levels and check some other hormones and things like that. I would have to do some research to give you like a really definitive medical answer, but you can definitely have people with too low and they're not being medicated, and it's just they're constantly passing out, and that's not good either.
Right.
That's relatively rare. Most people are just way too high.
Yeah. So they could just start smoking.
Yeah, exactly.
I'm just kidding. Don't do that.
Espressos.
Oh man. Well, anything else on stroke? I feel very informed after that conversation about it.
Yeah, I mean, other than that, just it's always a good idea to just know your family history. It's not etched in stone, but it's definitely somewhat indicative. Some people are adopted, they don't know, and then that's fine. You just kind of do the best you can, but bottom line, back to your previous question with the labs, just I would see your primary care doc once a year. I would get your labs done, blood sugars and electrolytes and kidney function and all those things, and get your blood pressure checked out, and just make sure everything's okay. They'll definitely let you know if something's getting too high, and then you just kind of focus on that. And that's the best way of preventing, and that'll keep you out of the weeds most of the time.
Yeah. Okay. Yeah. My biggest takeaway was just, sounds like diet and exercise. Yeah. Which I feel like is the answer to everything.
Absolutely. Diet, exercise, and definitely also staying away from like recreational drugs, things like cocaine and methamphetamines and things like that will definitely precipitate a stroke. Right. And a relatively healthy person. You can take a healthy person and expose them to stuff like that, and they'll stroke out.
Yeah, absolutely. Well, moving on to the next subject, mental health, and they are related from what I'm gathering now. Increased stress puts you into a higher risk category for stroke, both kinds. And, the mental health kind of crisis that's going on, I really just kind of want to address it. Men are almost twice as likely to commit suicide as women, right. Increased anxiety levels, increased depression levels recently. Just your opinion, maybe. What do you think is causing this steady incline in these symptoms?
Well, I think it's probably largely societal, and it's debatable, right? A lot of this stuff is up for debate. Right. But there's the theory that people don't really talk to each other anymore, and everyone's kind of in their phones, and they're on social media, and there's not necessarily that same sense of community that there was back when I was a kid, like in the 80s, people used to go out and
play manhunt.
Yeah. Go out and climb trees and ride bikes. And that was like the thing. And we played some video games, but that was like hit or miss. Whereas like now, it's like you get people inside for days, and they're doing that and on social media at the same time, actually. Yeah.
So just to touch on that for a second, this is kind of just something I thought of. Is it possible that someone is, so fixated on social media or video games that when they're not on it, they have increased stress hormones like cortisol? They're almost going through, do I say like withdrawal from it? Right. And that's increasing anxiety and depression. Is that possible?
I think that's definitely possible. I certainly don't have, any studies under my belt or any hard neuroscience under my belt where I can say like, this is the mechanism, right? Mm-hmm. But there seems to be a correlation between sort of like these dopamine hits from the social media and things like that. And then and definitely going into withdrawal and when you don't have it, definitely. So I think that has something to do with it. Certainly the, as we're all aware, the COVID, pandemic, epidemic, and the post-COVID period, which is not really post, but relatively post-COVID period. There's still, I think, a lot of residual angst surrounding that people can't even necessarily place their finger on. They just feel kind of uneasy, but they don't really know why. I think people had a lot of stress around that they probably just kind of pushed off to the side. Right. Or they had to, right? Like if you're working in healthcare in particular, then you weren't really allowed to freak out. Like you just kind of had to, deal with it now, process later sort of thing. So I think that's definitely a layer. Mm-hmm. Certainly the political climate is always going to be potentially a stressor for people, just because it's unknown and it's constantly changing, and people have their opinions about this and that kind of thing. So that's definitely going on. Right. There always seems to be a war going on. Yeah. So we, even though we're here in the United States, it certainly affects me. And I think it affects a lot of people, to turn on the news and see some of the stuff that's going on overseas. And those are our brothers and sisters. And it's just part of humanity. So as a collective, seeing another portion of humanity get feet down is going to affect you.
Yeah.
Even if you think it doesn't, and it's just over there, you know. And I'm not talking about taking sides or political affiliation or anything like that. I'm just saying your fellow humans.
Totally understand.
That's just really difficult to deal with. There's a high divorce rate, you know, which is likely related to what we're talking about. A lot of quick fix mentality going on. I see a lot of people just using one substance or other, whether it be, you know, vaping, cigarettes, alcohol, recreational drugs. I see patients that do all that stuff, you know, and they don't necessarily have the healthiest lifestyle and things like that. So you have all those things together, and especially if you're, you know, a vet to boot, right? You had your military time or whatever, and you may have emerged relatively unscathed like myself, or you could have been someone who really developed some PTSD, or they had some TBI or MST, military sexual trauma, and things like that. I have a member of my family who actually had some MST. That just adds even more. And then this culture is improving, I think, with this, but it's still very much geared toward men. It's not as encouraged for men, I think, to be completely open with their emotions. I think, generally speaking, men, this is just my opinion, okay? So hopefully I don't tick anybody off here, but generally speaking, I feel like for men, we're allowed to have two emotions, either anger or sadness. And the only time you can really be sad, crying, broken up, upset is like at a funeral, like that's fine. Or you just lost a family member or something like that. Otherwise, by and large, people kind of look at you sideways if you're responding to something with grief, like a grief reaction. Right. I feel it's just kind of like a very masculine culture that way. Whereas I feel like in many cases with the opposite gender, they're allowed to be healthy in terms of their expression, where certainly, I mean, same thing in my workplace. Like if I see a female that happens to be crying, I'll go over and ask like, hey, are you okay? Is everything fine? And I don't assume that it's anything gender based. Right. I just assume there's someone having a hard time. You don't ever see guys necessarily doing that. And then if you do, I feel like the ping level is much higher. Right. And again, based on my job and what I do, I see people in clinic all the time who are emoting, and they're very open, men and women, and they're very open with me about, you know, but it's the same thing. Like, men are more likely to apologize for shedding some tears. Women will apologize too. I don't want either one of them to apologize, because I'm here to help you. It's normal. So if you feel comfortable, like, awesome. That means that we're making some progress. Right. But it's just, I feel like there's a gender bias, and men really feel ashamed and they don't want to go there. And so they keep things to themselves, and they want to encapsulate everything. They want to wall it off. And a lot of times I'll see that where they've walled it off, and then they'll bring it to me, you know, and they think they can keep it walled off with me, but in many cases they can't. Yeah. And then that's when I'm like, okay, thank God, you know, thank God that you're breaking down with somebody, and now this is what we need to do, and then we can go through, you know, the various steps. But it's a very long-winded way of saying that I think it's deeply cultural, and I think that the culture is changing where it's more accepted. You know, I deal with my own mental health. We've talked about it, and I'm very open about that. I'm just like, yeah, I see a therapist once a week. For sure. Yeah, I take some meds for anxiety. You know, and I feel like when I admit it, it's more. When people are open about that, not that they have to be, but it's just more accepted. It's becoming more accepted. It's totally okay to just get some help if you need help.
Yeah, there's two things I want to expand on there. That was well said. Yeah. I appreciate it. The first one would be the quick fix mentality. But before that, let's talk about
that buildup of emotions you're describing.
Yeah.
Like it's not acceptable for men to express those emotions.
Right.
I guess that's kind of where society is right now, but it is important to have an outlet of some sort. So I think as men, we do feel like, you know, if it's me and a woman in a room and we watch a tragedy happen, you know, it's up to me to keep my composure, come to the rescue, make sure she's safe.
Correct.
You know, it's just in our DNA. And I don't think there's anything wrong with that.
Yeah.
But also when that situation's over, it's really important for me to do something with that.
Right.
So maybe some methods you have, I can shed some light on this too, of just, you know, whether it's journaling or seeing a therapist, what kind of things do you do to kind of, you know, after you're done being the hero, how do you, you know, settle those emotions?
Yeah, I was actually just gonna say that, like, so because I have to do that actually all the time.
I'd imagine as a provider, you see all kinds of problems.
Right. So it's like I have to be the column, you know, I have to be the firm, stable force in the room, right? And then, but then at the end of the day, I'm still left with like whatever was shared with me, and then I have to do my own sort of processing. So I definitely journal, lots of prayer, you know, meditation. I see a therapist. I have clergy people, I suppose you could say. Clergy is, I don't know, it's kind of a difficult word. Like it can either be a clergy person, like an actual clergy person, right? Or just people that you share your faith with, that you can discuss things with, right? And say, you know, can you pray for me and that kind of thing. I think that's really helpful. I do all the above. And family members also that you feel comfortable with. There are going to be certain family members in anyone's family who you would not share things with necessarily. So it's got to be with someone that you're comfortable with, who you can be yourself with. And, you know, your doc is always good.
For sure.
Right? And they can also get you set up with counseling and things like that if that's necessary. Absolutely nothing wrong with seeing a therapist once a month or once a week, just to talk about what's going on in your life. I think it's super, super healthy.
Yeah.
I wish I had started doing that 30 years ago.
At 18.
Yeah. Yeah.
Yeah.
You
I'm
know.
a huge advocate of just going to counseling in general. I've had a few in my life. I started when I was probably 26 after my second trip to Afghanistan. And I was seeing, she was an older woman, probably in her late 60s.
Yeah.
And I saw her for 3 years. And
Awesome.
I would just bounce ideas off of her. Sometimes I would go in there and we would just laugh at what's going on in life. And sometimes I was going in there with, you know, some pretty bad thoughts, and she, you know, saved me a couple times. So it's like, it doesn't have to be this very formal, tell me about your emotions. You know, it's really just like an unbiased professional friend that you can sit with and bounce ideas off of and get feedback. Maybe you're struggling to make a decision in life. They can help you work through it. They're not going to make it for you, but they can help you, enable you to get through it.
Right.
So there's so many different ways to use counseling. It's not just, you know, a dark room with a lamp in the corner with, you know, a notebook. It's a friend, you know?
Oh, it's brilliant. I mean, and it's unconditional positive regard from someone who actually cares about how you're doing though.
Yeah.
But they're not there to judge you. They're not going to put in their other people that you talk to. Potentially, they will slip in their agenda into your conversation. Like they want you to feel better, but kind of not really. Like not make you better than them. Do you see what I'm saying? Or I want you to feel better, but I don't want you to disagree with me on this topic or on this issue or whatever.
Right.
And that's the cool thing with a therapist is that you don't get any of that contamination in there.
Yeah.
It's just someone who genuinely cares for your positive growth and development.
Yeah.
And they won't drop any contaminants in there.
Totally get it.
At least on purpose, right? Everybody's a human.
Yeah.
But they won't produce any drag if they're a really good therapist. They'll only provide some lift for you.
Right.
You know?
Yeah. If you pull someone aside and, you know, hey, let's have a tough conversation.
Yeah.
I'm just really having a hard time with time management. Like I feel like every day I just don't have enough time to get everything done.
Right.
And then they go, yeah, me too, man. Like I'm so stressed. I totally understand. Like that's not necessarily helping. You know, you might need someone who can
compartmentalize their issue from your issue and listen, although they may also be struggling with time management, because I think we all are in a way.
Absolutely.
But yeah. And then that goes for both sides. Like if you're ever the listening ear for somebody, try and compartmentalize your issue from their issue and just listen instead of respond with your input, your life problem, because they're opening up to you for a reason. I'm sure you don't tell all your patients about your stresses as well.
Not everybody. It depends.
Right.
It's hit or miss. Sometimes it'll help.
To be relatable.
And sometimes it doesn't. More often than not, it actually helps because they have this idea that because I'm a doc, like I have no problems, which is so funny because it's like physicians are
immune.
Physicians. I went to this job fair when I was in middle school, I think it was, and there was, you had the job titles at each table, and I went to the one that said physician. I didn't even know what physician meant. I thought it meant like physicist or something. Yeah. So I was asking the lady, like, what's a physician? And she was explaining like, oh, it's a doctor and we see patients and blah, blah, blah. And she said, she's like, yeah, you need to be crazy to want to do this. You need to have a screw loose. Like there needs to be something, something wrong with you. And I didn't understand what she was talking about. In retrospect, I realized obviously it was tongue in cheek and she was joking with me and she was kidding. What she meant was that it's just a lot to take on. And this idea that you're gonna go out and save the world kind of thing.
Right.
Similar to even your job, same thing that you were doing when you were active, that's like superhero type stuff where you're protecting people and you're using ammo and you're wearing body armor and you're like this guy that can start a fire with like anything and you know what I'm saying? Like,
yeah, for sure.
It's just incredible. So it's like people, I'm sure, thought the same of you where they're like, oh, this guy has no problems. Like this guy has no issues. Like he's totally squared away.
Yeah, I guess so.
And it's like, no, like those are the people that have the hardest time in many cases,
Yeah.
So long-winded way of saying that's why I'll share with patients sometimes and they're like, they always say the same thing. Like, you're kidding. What, you? Like you deal with things? I'm like, yeah.
I got to hear all your problems all day, every day.
Right,
of course.
Right.
And being an emotional creature, I feel for you guys. That was my experience as a medic. Like people did come to me for more than just, they got shot or they have a broken bone. Like I got approached with family issues all the time.
Yeah.
Just because they don't know where to go. They don't want to go straight to the doctor. I was just the medic on a team. Like, hey man, me and my wife are really struggling, and I'm an emotional creature. So are you. It was really hard for me to detach from that because I would go home and think about it and feel for them. And like, I wish I could help everyone. I wish I had some kind of like magic thing I could do to just fix it. But I carried a lot of that stuff, and that's part of my personal PTSD is, I carry a lot of stories and a lot of situations that I heard about and was a part of that keep me up at night.
100%. I mean, I would totally go to you if I were in that setting.
I appreciate it.
100%. I would do that.
Yeah.
Yeah.
Well, what was the last thing here? Oh yeah. Quick fix mentality. That was the other thing I wanted to talk on. So I don't really know where I want to go with this, but I just feel like right now more than ever, it's really, really easy to just start stacking on solutions. Yeah. And these solutions quickly become the problem because we get so far detached from homeostasis, let's say, but just our genuine self. And just to run through a few examples, you have a 9-to-5 worker who's extremely stressed. Okay. They're drinking coffee in the morning. Nothing wrong with coffee. I drink coffee. 90 minutes after waking up. Exactly. And coffee in the morning, caffeine, maybe they're smoking cigarettes throughout the day, then they're drinking alcohol at night, and they're scrolling on social media, then they're watching the news, then they're drinking a 6-pack to help them fall asleep, then they're on an anti-anxiety, and then they're on something for ADD because they feel like they can't focus. Exactly. So like real fast, and that, I don't think that what I just said is out of the norm for an average person.
I see it all the time.
I'd imagine. And I think those minor little fixes become the problem very fast. So maybe you could touch on this a little bit. At what point do you feel like it would be more important to come off of things or separate from things versus stack on more things?
Right. I would say it's always a good idea to minimize. it's always a good idea to minimize, because I run into that quite a bit, what you're describing, where one thing sort of gives rise to the next thing.
Right.
I have a lot of people that take meds for sleep, and then they take, Adderall or something like that in the morning, like something that it's a stimulant. It's not really designed to be an upper, but it is an upper. It's a stimulant, but it's designed to treat a specific condition.
Right.
But what often happens is that the person will start to use that as actually the way that they wake up.
Yeah.
And just like you were saying, and then they'll use their benzodiazepine, their sleeping med, or they'll stack those up to finally fall asleep after being exposed to blue light for the last 3 hours, playing video games and, watching Netflix and whatever. And so I suppose, like, if anyone comes to me saying that despite all of these meds, I am still not sleeping, or I'm still overstimulated, or I'm still, or I can't get up in the morning, can we raise my dose of this particular medication or whatever? It's just kind of a certain feeling. And then it's also like when they start wanting to raise things and they're more interested in the meds than they are with like other lifestyle stuff. Like, hey, okay, so how's the exercise going?
Yeah.
How's the diet going? How's the journaling? Like, how's the family life?
How's your community?
How's the community? Right. And if they're focused primarily on just like their medication cocktail, that's when I'm like, okay, we probably need to start dialing down. And I'll make enemies that way. I mean, I've seen patients who got really angry with me for that. Sure. And some who just like don't even want to see me again, actually. And I'm like, okay, I mean, you may not realize that I have your best interest in mind now, but maybe a year from now you will,
Yeah.
So
yeah, I get real passionate talking about this because I see it in family members and friends and just everyone's just got so many things they're consuming. You know what I mean? Like from social media to medicine to vapes to alcohol to weed to I'm just like, none of those things by themselves are going to kill you, but you use 15 different things a day. And I just imagine, like we kind of started our conversation, that stress hormone, you start going through withdrawal when you're just sitting in a quiet room trying to relax. You're now stressed in the most, unstressful environments. Right. I find it kind of scary.
It is scary. So, I mean, like one of the best things you can do to sort of help re-equilibrate yourself. And a lot of people will say, well, I can't do this, within like 5 seconds of hearing this, they'll say, well, I can't do that. But one of the best things you could do for yourself once a day, 10 minutes, is just sit in complete silence, eyes closed, just breathing. Mm-hmm. You don't need to be repeating a mantra. You don't need to be in prayer. You don't need to be, it doesn't have to have a structure at all, but just sitting in that silence. That silence is really golden. I had a patient that came in the other day, actually, and a lot of my patients are really chatty while I'm working, So it's like I'm literally typing and listening to them at the same time, but I'm typing something different from what they're talking about, because otherwise I would never get any work done. So it pertains to them, but I'm back on issue number 2. They're on issue number 5. But I had a patient that came in the other day who we had our exchange, and then we knew what I was going to do. And then I started typing, and he just got really quiet, and he was just kind of just in his, it's really difficult to describe. He was in his space. I was in my space, and there was this calm that just came over the room. It was like this supernatural calm almost. And I was like almost emotional about it. I was like, what I really appreciate about you? And he looked at me like, what could you possibly appreciate about me? That's the way he looked at me, And I'm like, come on, man. Because I really like this guy too. I was like, I just appreciate the fact that you like gave me a second to just collect my thoughts and like write something. I was like, nobody ever does that. People never give me that space. And it's not a complaint. I'm not complaining. I'm not whining. I'm just saying that some people feel like they need to be doing that. Right. You know what I mean? Like they're uncomfortable with silence or whatever. Talker. Sure. Or they want to get everything in, or they feel like they're being rude if they're not talking or whatever. So it's like, I understand there are different reasons, but that silence, man, is just so golden.
Refreshing.
Oh my goodness. If people could just embrace that a little bit more every day, they would, a lot of those stacking of substances that you're talking about would just naturally go down.
You won't need them.
Yeah.
Yeah. Yeah. I'm a huge advocate of doing that in nature also.
Absolutely.
Nature is I think we talked about this on our last one, just such a healing modality in itself. Just go sit in the woods somewhere for 10 minutes and do your silent exercise. Because you do it in a city, like, I don't know, man. I hear a dog barking, I hear doors locking, I hear this happening, I hear someone screaming at someone. It's so hard to do it in a city, but
it's really hard.
Yeah. Well, yeah. I wanted to bring that up because I feel like that, what do we want to call that? Like healing modality stacking of some sort, I think it has the possibility to get out of control. And, I don't know what happens to society when that happens. I just think it would be a scary thing. You have a lot of people on a lot of things. What would happen if something, what if you couldn't have them anymore? Your insurance dropped you and now you can't have your medication. And now, something else happened and you don't have, you have a health issue. Now you don't have the alcohol to lean on. And now you're actually stuck in that silence with just yourself and you can't handle it.
Well, that's what a lot of people are running from, is that silence, actually.
For sure.
Yeah.
Do you have any recommendations for getting more comfortable in that?
With the silence?
Yeah, just yourself. Because I think that's what it is, right? It's just yourself and your own thoughts and silence.
Yeah, I do actually. There's, I don't know if I can mention an author's name, but there's a spiritual teacher, loosely termed, right? I'm going to say in quotes spiritual teacher because it's not like a specific denomination or anything like that. But he wrote several books. His name is Michael Singer, and love this guy. He's got a podcast and with Sounds True on YouTube, and he's got several books out and things. And there's one technique that people can employ that I've learned from him, where anytime an issue is coming up, and you'll always know when an issue is coming up, right? Because you can feel it. It's usually in your chest.
Right.
It's pressure, it's tightness, it's pain, grief, anger, whatever it is, anxiety, something. And it's usually like in the belly or it's in the chest. A good way to really actually transmute that ball of mess into its opposite and to clear it out of your system is just to focus on it and just to kind of mentally acknowledge that you're aware of it. So the way to do it is just to say, well, okay, I am pure consciousness, I'm pure awareness, and I observe that there is discomfort in the chest, or I observe that there is pain in the chest, or tightness in the chest or in the belly or whatever. And you just see it. That's it. And just like relax. He has this technique that he calls relax and release, where he's just like, you find it, you lock in on it, you relax, you release. And what you'll find is that as you're looking at it, as you're being aware of it, it'll actually just, the light of your consciousness focused on this ball of thing, whatever that is, will actually just start to dissipate on its own. And it doesn't all go away at once. Sometimes it's in layers. Sometimes like 10% of it will clear off, and then the remainder will move over here. You know what I'm saying? And then you follow it, and then maybe another 10%, and then it'll move over here. Or it'll try to distract you and do a different thought or a different emotion or whatever. Then if other stuff comes up, then you just do the same thing with that. Mm-hmm. And you'll have moments where you'll just feel that emotion just kind of disappears. It just goes, and you'll feel like this clearing and this sense of lightness and this sense of peace. And what you're doing is basically transmuting that. It's called a samskara. You're transmuting that scar, that energetic scar, that grief, that fear, that pain that a lot of us are still holding on to from childhood, from past relationships, from past work situations, whatever. You'll actually transmute that into its opposite.
Okay. So it's almost like spiritual white blood cells, like you're sending a signal to this area to fix it.
Absolutely.
I like that.
And there's something about shining the spotlight of your consciousness on exactly what you don't want to look at in the silence that will help to transmute that into the light of consciousness.
Yeah.
And that's getting very woo.
No, I'm all for it, man. I mean, not to brag, but I don't take anything. I'm like just very clear right now. Like I have no like exogenous forms of anything that I take, which hasn't always been that way. I was on 3 different medications when I got out of the military. I experimented with medical marijuana for a while. I started to slip into that. So that's kind of why I'm passionate today. Yeah. Because I felt myself slip into that. And I wasn't an extreme case by any means, but I started to feel it. Right. I think I felt like I needed more this or more that. And it was in those thoughts that I realized I needed to separate from that. That's when I found meditation and exercise and diet, but I won't get too far into it. Yeah. Just to wrap up, I'm curious, as a provider, is there anything you're kind of passionate about right now? Just like a little niche thing you're kind of studying, or? Yeah, I pretty much what we were just talking about. I'm very passionate about, always mental health, and dovetailing that with spiritual health. And spiritual, again, doesn't necessarily mean, you're a Catholic or you're a Buddhist or you're a Protestant or whatever. It's not like a denominational kind of thing. I think people should do whatever works for them. Right. Right. So it's not like a religious thing, but I feel like in the society that we live in right now, what we were just talking about, people being relatively secluded from each other and looking to a lot of quick fixes and being very cut off from one another. I think they're also cut off from themselves, and they're running away from that silence, and they're looking to fill that with, in many cases, as much noise as possible, just to kind of distract them. Like, I don't want to think about that. I don't want to whatever. And if you let yourself, I always encourage patients, along with everything else, either meds, not meds, depends on the situation, lifestyle changes, that kind of thing. I always try to bring up the silence component in one way or another, whether it be meditation or whatever. Journaling is another form of silence, and just really reconnecting with yourself. I feel like a lot of people don't know themselves these days. For sure. I think they think they know themselves, myself included. I'm still learning who I am. Do you know what I'm saying? Yeah, I totally understand. Yeah. I'm learning who I am every day. I'm like, oh, wow. Like, okay, I'm actually not, in some cases, who I thought I was, like, even last month. Like, a lot of these things were just conditioning, or someone told me I was this when I'm actually that, or they told me that I should feel this way when I actually feel that way, that kind of thing. So I think a common route would be, we don't know ourselves, but we how do I word this? I'm very passionate about this. We're becoming who we think other people think we are versus who we actually are. Right. And through that, we cause ourselves to have anxiety and depression because we're out of touch with who we are. Yes. But we're in touch with what we think everyone else thinks we are. Right. But in reality, we don't know what anyone else thinks. Correct. So what are we actually doing? 100%. We have no idea, which is why I like to use a lot of humor, and I'll kind of, it's not hard for me to stay humble because it's like, I'm very human. So I say humble in that I like to kind of gently poke fun at myself, and I'm always joking in that way. Do you know what I'm saying? Yeah. Just to keep things light. And it's like, I definitely don't have all the answers, and learning never stops. And when you understand that, you'll be humble forever. Yeah. Yeah. Well, maybe this is what we'll get into on our next episode. Sounds good. Cool. Well, I appreciate it, Eric. Thanks for coming on the show again. Thank you for having me, sir. Stay dry out there. Definitely. Outside. We haven't heard any thunderbirds today. Yeah, that's true. But there's a moth in here. Probably still there's one thunderbird in here. All right. Take care, brother. You too. Take care.